Hello, everybody. Welcome to HBMA Live again. I know you must be looking at my fancy shirt and fancy jacket, but thank you so much for joining me here on LinkedIn, YouTube, and HBMA Group. For those who are first timers and listening us here, we have a group called HBMA Healthcare Business Management Association. It's one of the largest association of medical billers and coders in United States. Our membership has companies, small companies, large companies, management groups, and individual medical billers and coders. So it's a great group which likes to share wisdom occasionally through our conferences. We have 3 or 4 in-person conferences, and this year our next conference is in St. Louis on September 15th to 17th. It's a fall conference, and I would invite our executive director, Brad Lund, to talk about this conference in a few seconds. So Brad, how are you doing this morning?
I'm good. Thank you so much for inviting me, Kunal.
No, absolutely. Let's talk about the conference first before we invite our guest, Kayley Jaquet, who will talk about the subject. So we know what we are doing in our conference, and our listeners and our audience and people who are listening to our LinkedIn Live today would get to know what exactly we are doing and what could they expect in the conference.
We've got a full lineup of speakers on a variety of topics. We actually have 17 speakers. We're going to start at noon on Thursday and we'll end at noon on Saturday. Not only is the education going to be phenomenal, but we have got some social events, both in and outside of our exhibit hall, that you are going to leave St. Louis invigorated, not only in the
I like that word, invigorate.
You're going to end up with lots of new friends.
Yes,
I promise.
That's the most important thing, and I really cherish that friendship I have developed over a period of 18, 19 years. Being we know each other for almost 15 years, I remember.
Absolutely, almost 20 actually.
Yes. And I remember we were a very small billing company at that time, and it really helps us out to be associated with the industry association and peers. So we are hopeful to see a lot of people this year in September in our conference for at least 2 full days and 2 full lunches, 1 breakfast, 1 lunch. That's what I'm guessing, right?
Most importantly, 2 receptions with a full bar.
2 receptions. And that is then a fantastic opportunity to network with offshore vendors, people who are doing billing in India, peers who are doing billing in different specialties at our conference, and most important, innovation and new product development. And
right.
We have a roundtable. I remember we were talking about in the board meeting.
We've got roundtables. We'll have 45 exhibitors at this conference. That no place you're going to be able to get as much information as quickly as you can in that exhibit hall with 45 different exhibitors.
How can people register for our conference?
The conference registration is open on our HBMA website. Just go to hbma.org and right. Click education, and you'll see the conference registration right there.
So as you speak, I'm typing so that we can ask people to go on this website, and then this is the website, right? hbma.org.
Yes.
Perfect. So this is the site. Anybody can go out there and they can register, whether you're an individual medical biller, coder, or you are a company, you want to engage your employees and learn some wisdom about medical billing and coding, wants to update yourself. Even if you're a medical practice office, you want to send your employees or medical billers to our conference. So with this, I would like to invite, thank you, Brad. Thank you very much.
Thank you.
Yep. With this, I'm very excited actually today to talk about this particular session and the subject. The title is How Radiologists Can Increase the Reimbursement. The current reimbursement, and Medicare actually has some unique programs. I was reading about it where they want to actually help. CMS wants to help radiologists and imaging services to make a little bit extra money and incentivize through CDSM. And we are going to learn more about it, what it is, and what program it is. So what happens under this program, a practitioner orders an advanced diagnostic imaging service for a Medicare beneficiary. He or she or clinical staff under his direction will be required to consult a qualified clinical decision support mechanism, and that is called CDSM. It is nothing but it's a technology, it's an electronic portal through which appropriate use criteria, AUC, is assessed. And when you assess this, we are going to learn how it helps in billing and how it increases the reimbursement for a radiologist. So with this, I would like to invite my co-guest, Kayley Jaquet. She is a wonderful female, and we have been interacting with each other for some time. Welcome to the show, Kayley.
Hi, good to be here. Glad to talk to you all this afternoon.
Absolutely. So Kayley works for Advocate RCM. It's a company based out of Ohio.
Yep, Dublin, Ohio.
So tell us a little bit about yourself before we really start diving deep into the questions.
So again, my name is Kayley Jaquet. I have been with Advocate RCM for the past 3 years. Under my purview within the company, I work primarily on quality, compliance, and reimbursement related issues, mostly related with Medicare. One of the primary things that I work on is the merit-based payment program, or MIPS. I help our clients reach the goals of that program. We also run a registry service for the purposes of submitting data. And of course, we have the appropriate use criteria mandate that we're preparing for that may be beginning in 2023, depending on the COVID public health emergency. So
yeah, how's 2023 look for? I mean, how do you see 2023 coming in, and especially for radiologists and diagnostic services? This was an interesting subject because, and when I was talking to David, I think that David is the owner of your company, David Jeter.
We've got Todd Walker and Kirk Reinitz, probably the ones that you were talking with. Maybe.
Oh, okay.
Yeah.
So they said, why don't you contact Kayley and then see if you guys can have a session? So tell us a little about this act, what is called PAMA, P-A-M-A in 2014, and then CDSM, and so walk us through how it is interesting to bill and how it helps to make a little bit more incentive from Medicare beneficiaries.
Yeah, absolutely. So the mandate itself was part of the 2014 PAMA legislation, as you mentioned. What that legislation did is it basically directed Medicare to establish a program for ordering providers that would basically look at their patterns for ordering advanced imaging studies and try to assess those patterns to make sure it's the most appropriate for Medicare beneficiaries. So part of the idea is that it would potentially cut down on unnecessary, or what they consider unnecessary services or exams, reduce the amount of radiation that Medicare beneficiaries could potentially be exposed to, and again, sort of a cost control measure. So the mandate itself requires ordering providers to consult appropriate use criteria through use of a qualified clinical support mechanism, or CDSM, as you were mentioning.
Which is technology, which they say it's a portal.
Yes.
So it's a portal. Every diagnostic center or radiologist has to have access, just like through PICOs or MIPS, something like that.
Now, this is actually something that your ordering providers need to do. The radiologists are in an interesting position with this mandate because they are required to pass the data along on their claims for the consultation, but they're not actually the ones that are allowed or supposed to be doing this consultation, unless they're ordering it for, a patient, of course.
So it's the PCPs or specialties and neurosurgeons, neurophysicians, orthopedic, anybody who is ordering, let's say, MRI or PET scan or something.
Yes, exactly.
Why would they do it? Why would they go and help radiologists to increase their reimbursement? I mean, it's just common.
So the reimbursement piece, it's actually not an incentive. The way that the program works is the ordering providers are responsible for doing this consultation. The furnishing providers are responsible for taking the results of that consultation in the form of modifiers and G codes, put that onto their claim, and then put that through to Medicare. If they do not have those modifiers or G codes on an applicable claim, once the penalty phase begins, which is 2023, that means that those claims are going to be denied for your radiologists. They're talking about a return process where they would provide some feedback to tell you what was deficient. But essentially, unless the radiologists are getting these modifiers and G codes from the ordering providers, they're not going to be paid for these advanced imaging studies.
So actually, their billing, the performance of their billing department depends on the ordering physician's department. They need to communicate very well.
Yes, exactly.
So communication is very important in this whole process.
Yes, exactly. Wow. So if you are within a hospital, you're probably going to have an easier time getting ready for this mandate to begin, because the hospitals will need to also have the same information on their claims to make it all the way through the process. But if you are in, let's say, like an outpatient imaging center or something like that, the ordering provider compliance is going to be your biggest challenge. And I'm very glad that you're doing an event like this, because even though the program's technically been around for a while, it's gone through several delays. And I think that has reduced.
January 1, 2023, it's mandated. They're going to.
It was supposed to start in 2020.
Right.
Yeah, it was supposed to start several other times, but it's been pushed back and pushed back. And I think part of that has made it difficult for ordering providers to pay attention to and kind of know what's.
But this will impact across the board, all diagnostic procedures. It's not billing of diagnostic procedures, right?
It's not every single diagnostic imaging procedure. It is limited.
CT, PET scan, nuclear medicine, MRI, top like 3 or 4.
Yes, yeah, kind of your biggest ones.
Yeah.
And it does depend on the setting of where those exams are being ordered. So it is limited to your outpatient settings effectively. Right. Critical access hospitals are somewhat exempt. However, they're going to have to be able to also pass along a modifier to tell us that they're exempt in certain situations. What do they mean
by appropriate use criteria?
Yes. Okay. So appropriate use criteria is basically just a set of criteria that deems if an order is appropriate for a person. So it looks at, the patient's age and demographic information. Appropriate use criteria is established by what are called provider-led entities. So these are usually specialty societies, like the American College of Radiology is a big one, or cardiology. So those entities are charged with creating and maintaining this appropriate use criteria, these systems. But then the CDSM vendors that create the tools, they are the ones that take that appropriate use criteria and build it into their digital tools and solutions. So really,
are these practice management and EMR companies going to jump into this? So very soon this will be the part of that program, like
a lot of them already are. Epic, for one of the big ones, has an integrated CDSM system. I believe that they have licensed, or they can work with multiple ones, but they try to use Care Select from the ACR. Lots of other, EMR systems.
I'm guessing you guys do radiology billing, right? It seems like you guys have. So is there any changes or for billers, coders, how it is going to impact them?
Yeah. So I think biggest part of that is to know which claims and settings are applicable. So there are guidance out there from CMS that have those particular CPT codes, as well as the settings that you want to look under in terms of place of service of where the mandate's going to apply. So you can, from a billing perspective, try to automate that and to say, hey, these are going to need a modifier. The second part is that as a billing vendor, we have been working with our clients on setting up the data flow to pass this information along. So the way that it's different for everybody, of course, but the way that we're commonly seeing it is that it can flow from where it's sent from the ordering provider standpoint, bypass the radiologist, so they don't even have to see it anyway, and go straight to the claim through usually the HL7 or ORU fields. So
what are the fields which basically the coding information, like the CPT, ICD codes and the appropriate modifiers?
Yeah, it's typically been, at least our clients are using the HL7 fields to send that data. You could also potentially have it go straight onto the radiology report, and then coders could read off of that to apply the modifier. But basically, the modifiers are 3 of them are related to, was the claim appropriate or not? Yes, no, or we didn't know. Those modifiers need to have what's called a G code also built onto the claim that would go on a separate line. And that G code is essentially just the code for whatever CDSM system was used. So each one of them has their own unique code. So the order providers have to figure out how to pass that information along in a place where the furnishing providers can pick it up. And then that has to get all the way to the claim.
So is it something like we used to file those individual incentives, what is called PC? Physicians used to apply for incentives, and they used to add G codes in order to get those incentives. Something similar to that?
Not really. So I think you might be referring to PQRS.
Exactly.
Yeah, type quality reporting. I mean, the G codes, they're the same kind of thing. They're a HCPCS code that tells you a quality,
additional codes. Yes.
Yeah, but the biggest difference is that these codes are going to get assessed on a per claim basis for either reimbursing or denying it. Whereas, your PQRS reporting results in like a bonus or a penalty.
Correct. Both ways, yes.
Mm-hmm. Yeah.
Now, at somewhere I also saw that practitioners whose ordering patterns are considered outliers, they would be subject to prior authorization. What does that mean?
Yes. So this is actually one part of the mandate that hasn't been completely flushed out by CMS yet. I would anticipate we'd hear more about it this rulemaking cycle, but effectively what the goal of the program is to monitor the patterns of these ordering providers, right? So after the program begins the penalty phase where they're actually using this data, they're going to look at a set of 9 clinical priority areas and look for your outliers within that smaller sample. So these priority clinical areas are things like back pain, headaches, more the reasons for imaging that are commonly found to have unnecessary imaging. So that's a place that they're going to look at first. CMS is going to identify up to 5% of the ordering provider population and make them subject to these priority
auditing. So they would have a random auditing for those claims.
So they actually haven't told us. My assumption would be based off of those modifiers.
Correct.
If you're not sending any modifiers at all, then you're out of compliance. If you are sending a high amount of modifiers that say that your CDSM told you it was inappropriate for the exam, that's more likely where they're going to look. However, they've also said that they don't want this program to be a hard stop to the ordering process and that you can still order things that are considered inappropriate. The radiologist will still get paid for things that are inappropriate. So that's a big thing that we still don't really know. But it will have something to do with the modifiers that you report.
And who would help me understand this? I'm not a coder, by the way. So, but I understand the billing process. In a normal physician environment billing process, physician or a certified coder, physician can add the modifiers based on his understanding. And then if certified coder has to go through the report, then he goes to, and then he does the coding and add the modifier. In this scenario where they have to consult a CDSM, who would determine the use of the modifier, CDSM or physician office or ordering physician?
So if you have a CDSM tool that's integrated into your EMR system, those are typically going to prompt you to go through the CDS process at the time of ordering. So essentially the system will say, hey, you're ordering an advanced imaging study that is for a Medicare patient in a setting. So it'll have a pop-up that says, please enter in this information. That does your consultation for you. And then typically, like with Epic, the code, the modifier will go ahead and flow through to wherever you set it up through with your data set. If you don't have that, if you don't have something that's automated like that to prompt you, then it's up to the ordering providers or their clinical staff to do this consultation. So there are free tools that are available that are kind of standalone. You don't have to have them integrated. The ACR has one that's fairly easy to use. You plug in some information and then it would produce the modifiers and G code that you would want to pass along at that time. If you don't have it integrated, then it's going to be a little bit manual and you're going to have to figure out where that goes, when you pass along that order. Another thing that we're hearing pretty commonly too is if, a patient goes from a referring provider to a radiologist through the scheduling department, those front desk staff are now kind of at the triage of looking for, okay, did we get an appropriate use criteria information with this? And if not, then they reach back out and try to get that before they'll schedule the patient. So
How are you? I mean, this is a little bit complex to me. I mean, think about in our scenario, but are you guys doing any teaching material, education to the doctors, practices how are you guys handling as a billing company?
Oh, yeah, absolutely. And I think the education piece is one of the biggest challenges with this whole mandate, just based off the way that it's set up. We have a lot of educational tools that are available on our website. We do webinars regularly. We'll continue to do them throughout this year. We've got lots of ones from last year, the year before. We also have several articles and references, links within those to other references. So we have a lot of information on our website. So
but do they really people follow? It's like your clients and your
it's a very response. Our client managers are the ones that really work with our individuals on getting them ready and trying to keep them on track. It's a really mixed bag. We've got some that are like, yeah, let's get it done. We don't want to worry about it anymore. So of course, once you have your data flows set up, then you can work on your ordering provider outreach. But we have some that are waiting to see what this PHE does, some to see if it gets thrown out altogether before they really want to commit a whole lot of time to it. But honestly, it does look like it's coming. I would say go ahead and get ready now. Don't wait till October or November, and do whatever you can to make it easier once 2023.
So while I was reading about it on CMS website, it's, by the way, guys who are listening to us, all of this material is from CMS website. You can go on CMS, search for CDSM or appropriate use criteria AUC. You can find a lot of details. But one line, it says clearly that this new program is to increase the rate of appropriate advanced diagnostic imaging services provided to Medicare beneficiaries. So I'm guessing that there must be some kind of increase in the reimbursement, right?
No, it's
what
really
does that mean?
about
Increase the
cutting
rate of
down on the ones that aren't appropriate. So yeah, there's no bonus, there's no incentive. Your only incentive is to preserve the reimbursement that really you're
otherwise
doing.
you will not be getting paid.
Exactly. Yep.
So either get paid if you have to pay. If you have to get paid, you have to implement this
Yes.
in your medical practice, no matter. and you have to have a nice communication with the ordering physicians. So there would be more engagement between an ordering physicians and the diagnostic clinics always required. And if one person is falling, is the other person is losing money because of that.
Yep.
So that's interesting.
Yeah.
Uh,
It's an interesting approach.
yes, it is a very good, yeah.
Yeah. Mm-hmm.
Well, it has a lot of other details as well. And normally we talk about 25, 30 minutes. Do you want to share anything else which is a challenge about this process, and what's the advice you give to the medical practices?
Yeah. I mean, I think the biggest challenge is it's been delayed several times. It's changed several times, trying to keep up with what you need to do to get ready for it. Once you know that, the biggest thing is prioritizing any technical upgrade, update, whatever, prioritize that, get that out of the way. And then the next thing is to work with your referring provider community to make sure that they're ready. Depending on your position, you might have an easier time with that than others, but it's really going to be that communication standpoint of making sure everybody knows what they're supposed to do come January. And another reminder too, for the ordering providers out there, that this is the law. The law is technically stating you have to be the ones to go through this consultation process. It would take a change in the law to get rid of this mandate completely. CMS is
which is not possible, which is remote. I don't
it's
think
got, yeah, it's
already
pretty
postponed.
unlikely.
Like MIPS, that was happening, but eventually it happened.
Yeah, we've seen some hopes of reports being ordered to Congress to review actually MIPS and the appropriate use criteria mandate this year. Wouldn't count on it. It's best to protect yourself, get ready for it, and do what you can now.
But this is my last question. What advice you have for the billing community? How would they prepare themselves? Any reading material, anything they need to do, any special codes or anything? What suggestion you have for billing community?
Yeah, so from a billing standpoint, you want to check and make sure any sort of systems that you're using, whether it be language processors or other type of things that flag.
Is it affecting both CMS 1500 and hospital?
Yes. Yeah, 1500 and your 1450 claims.
Would there be a change in the form, in the information?
It shouldn't, because you would append the modifiers onto your primary CPT code, and then your G code goes on another line.
So just update the charge master, right? If people have charge master or charge, update it with those codes so that you remember it from January 23 onwards. But is it people who started already doing it?
Yes, the program has been operations and testing year for the past couple years. So you can definitely send these codes across now. The MACs will accept them. You're not going to have anything get denied or kicked out, even if it's incorrect or you have things missing or what have you. So we still have a couple months left in the testing year, so you can go ahead and make the most of that.
Fantastic. I hope to see you in St. Louis if you're coming. Are you planning to join HPMA conference?
I'll have to check with the higher ups and see if I'm in the budget to attend.
Well, we had a great session here, so thank you very much, and look forward to. I think probably we are going to do some more webinars on this with you.
Okay, yeah, absolutely.
Thank you so much. Thank you, Kayley.
Thank you. Have a good day.
Thank you. Oh, Brad, you're back. You have any information to share anymore, or we are done with today's session? Looks like we had a great session today.
We had a great session, and you're a wonderful host. Thank you so much for doing HPMA Live, and thank you, Kayley, for all that wonderful radiology billing information.
Fantastic. So we'll see everybody in fall conference and September 15th, 17th. Website is on the you can see the link, hpma.org. Even if you are somewhere remote, please try to come and use resources which are available for free on hpma.org. We have different types of membership out there. You can join any membership. It starts just a little bit, Brad. What is our starting membership on our website?
The individual RCM membership is $495.
$495, right?
Yes.
Okay, so in $495, and then we have a student membership too, right?
There is a student membership of $200.
$200. So think about it. If you are a certified coder, you are into some education program, with $200, you can become a part of this organization and add value in your own self, in your own career. So with this, we look forward to seeing you more often in our conferences and in our live HBMA Live. So thank you very much. Have a great day.
Thank you, Kunal.
Thank
Goodbye.
you. Goodbye.